Let's highlight now another disease that is not a diffuse parenchymal disease, but a disease that actively contributes to hypoxia and can result in both HPV and pulmonary hypertension, and that's obstructive sleep apnea. So what patients do we think about that may be at risk for obstructive sleep apnea? Well, those are obese patients, patients with various heart diseases, type 2 diabetes, stroke, and pulmonary hypertension. So what exactly is sleep apnea? Very simply, it's just a floppy airway from the upper airway to the tracheal rings. And that lack of tissue turgor can worsen over time with different diseases, with obesity, and with aging, making sleep apnea more common as patients get older. The majority of this obstruction occurs at the base of the tongue, but can occur at multiple regions from the back of the throat to the upper airway. Generally, for patients with sleep apnea, we think about those who have excessive daytime sleepiness, gasping or choking at night, witnessed apneas, or loud snoring. But there are other features that are not classic that I want you to pay attention to and may be more common in our elderly population of patients. And that may include sleep fragmentation, insomnia, morning headaches, getting up and going to the bathroom frequently, even though a lot of times we attribute that to a BPH, that potentially could be related to sleep apnea, as well as memory loss, decreased concentration, and mood disturbances. On physical exam, we have some clues that also may help us in addition to the history that we reviewed. Look at the BMI. BMI greater than or equal to 30 is certainly a risk factor. Shirt collar size for men at 17 inches or higher is a risk factor as well too. Assess the airway. Is there lateral crowding? What's the Malin-Potty score shown here? Or is it wide open at class 1, or are we more obstructed at class 3 or class 4? How large is the tongue? Are we seeing an elongated uvula? Are we seeing nasal abnormalities, or is there a history of septal deviation? So what do we see that's illustrative of sleep apnea when we look at all the squiggly lines on polysomnography? And I'll ask you to look about 2/3 down on the left at the NP, that stands for nasal pressure, and the airflow channels. And if you'll notice, for about 2/3 of the tracing, they are flat, meaning airflow is not going through the airway. But if we look further down at the thoracic and abdomen readings, we'll see there's a nice sinusoidal movement of the chest in the thoracic region and the abdomen, showing that the patient is still trying to breathe against a closed upper airway without any airflow going through. When we look at a chart or table of the oxygen saturation in the second bar here, you'll notice how severe a person with normal oxygenation during the day can desaturate at night with sleep apnea. And this is our trigger for hypoxic pulmonary vasoconstriction and pulmonary hypertension related to sleep apnea. We began to find that more commonly in patients with IPF. So we decided to ask the question, what is the true prevalence of sleep apnea in patients with IPF? So we took 55 subjects with IPF and had them do sleep apnea questionnaires and ultimately the same nocturnal polysomnogram. And we found that the majority of patients, 68%, had moderate to severe sleep apnea and only 12% had no sleep apnea. And I think this highlights that many of the questions that we as pulmonologists and physicians ask during the day, are you short of breath, are you coughing anything up, are you wheezing, are related to awareness and wakefulness. But there is 1/3 of our day we need not forget, and that's sleep. And breathing and physiology during the sleep is very different than during wakefulness. What have we noticed about HPV and obstructive sleep apnea? Well, intermittent hypoxia certainly results in hypoxic pulmonary vasoconstriction, and that may be worsened by obesity, as obesity can upregulate adipocytes to make adipokines and be pro-inflammatory. In REM sleep, we find that it's associated with an increase in pulmonary artery pressures that can be independent of hypoxia. Hypoxic stress is occurring with monocyte macrophage activation, and we're finding that plays more of a role these days in idiopathic pulmonary fibrosis. We also see increased oxidative stress, increased inflammatory markers, increased sympathetic activity, especially noting when the heart rate should be lower at nighttime when we sleep, and increased endothelial dysfunction that ups our risk of cardiovascular disease. 2 recent studies noted that the sleep oxygenation, or the desaturations that occur during sleep, can exceed that with maximal exercise, and that the lowest saturation during sleep was directly related to survival. So we need to pay attention to sleep. How do we treat this? Very simple. We use airflow provided by a mask to keep the airway stented open and keep it from occluding, and ultimately stop the recurrent desaturation events that occur. Olivia Giddings back in 2012 published an abstract with American Thoracic Society that noted that the treatment of sleep apnea and IPF was associated with improved survival. She did that by looking at patients who were compliant by Medicare standards with their CPAP versus non-compliant, and found that those who were compliant with their CPAP had an improved survival and fewer deaths in comparison to those who were non-compliant. Those findings were echoed by a group in Greece that found that effective CPAP treatment for patients with sleep apnea and IPF did improve survival, activities of daily living, and quality of life. So in summary, Group 3 pulmonary hypertension is defined by the New World Symposium in pH criteria, and we have 5 different categories for that. While hypoxic pulmonary vasoconstriction may correct the ventilation perfusion mismatching, chronic hypoxia can ultimately lead to vascular remodeling with muscularization of the pulmonary arteries, endothelial dysfunction, and then loss of pulmonary vascular regulation. Obstructive sleep apnea, in addition to interstitial lung disease, can also cause pulmonary hypertension, and really needs to be on our radar for treating patients and looking for sleep disordered breathing or sleep apnea in our patients with chronic lung disease. Thank you for joining us today. I really hope that you gleaned a lot from this program and have some clinical pearls to take back to your practice.